Good morning. Welcome to another episode of Pathagonia. So today I'm going to go over the lower anogenital squamous tract, or LAST, project and some updates. So most squamous cell carcinomas of the lower anogenital tract are caused by HPV, or human papillomavirus, and similar terminology is used for all HPV-associated squamous lesions of the lower anogenital tract. And I would highly recommend you click this link and you check out the LAST project. It's a really good paper where a lot of these guidelines and updates stem from. So an HPV infection can follow two main paths. The first of which, HPV infects the epithelium to support virion production, leading to LSIL or condyloma, which is often transient, self-limited, and the infections often regress. And this is considered low risk. Secondly, HPV can lead to the viral oncogene overexpression, causing clonal production of undifferentiated cells, leading to HSIL, which is precancerous and often has persistent infection, although it can regress, rarely, and this is considered high risk. So this is a really nice schematic for visual learners. So for LSIL stands for low-grade squamous intraepithelial lesion and includes condyloma. So LSIL refers to IN1, and that could be CIN1 or AIN1. We'll get into that a little bit more, but if it's intraepithelial neoplasia 1, you're going to be having coilocytosis, so you're going to see coilocytes more superficially, and the dysplastic basal cells are limited to the lower 1/3, which you can see here by the purple. So if it's the dysplasia is limited to the lower 1/3, that's typically a sign of LSIL, and the mitoses are commonly also in the lower 1/3. And P16 IHC is often negative, although it can be positive, so good to be mindful of that, and that paper goes a little bit into that as well. And just before we move on to HSIL, obviously in normal epithelium you're going to have no coilocytes. Dysplasia is going to be absent, but the nerves may be more prominent, and mites are typically only going to be in that basal layer, but that's okay, that's still normal, and P16 is obviously negative. For HSIL, or high-grade squamous intraepithelial lesion, which would be IN2 or IN3, which again could be AIN2, CIN2, CIN3, AIN3, depending on what part of the body you're in. So for high grade, coilocytosis may be seen, but not always. For IN2, the dysplasia is going to extend up to the 2/3 of the thickness, as well as the mitoses may be found up to 2/3 thickness, and P16 is often going to be block positive for high grade. For IN3, CIN3, AIN3, coilocytosis may be seen, but the dysplasia, importantly, is going to be full thickness. Mitoses can be full thickness, so found all the way up to the surface, and P16, importantly, is going to be block positive. So as I alluded to earlier, there's different abbreviations for different sites. Site abbreviation plus IN is how it's done. So AIN, or anal intraepithelial neoplasia, PAIN, or perianal intraepithelial neoplasia, PIN, penile intraepithelial neoplasia, CIN, cervical intraepithelial neoplasia, VAIN, or vein, vaginal intraepithelial neoplasia, and VIN, or vulvar intraepithelial neoplasia. So moving on, we have some LSIL cytologic changes. So what are you going to see? You're going to see mature keratinocytes with lots of cytoplasm, with enlarged nuclei, typically 3 times larger than the normal intermediate cells. That's kind of the clue that we use from cytological standpoint. You want to see those nuclei 3 times larger than an adjacent intermediate cell. With nuclear membrane irregularities, you can have hyperchromasia. They can be racinoid, as you can see here in this coilocyte. It looks fairly racinoid. as well as perinuclear halos, or clearing around the nucleus, and they can be multinucleated. For HSIL, the cytologic changes, you're going to see immature keratinocytes. So the reason that the cells stay large from the base to the surface is because they're not maturing. So these are immature cells, which is problematic. And you know they're immature because they have a high N-to-C ratio, kind of like a blast in the heme world. But if a cell's immature, it's going to have a lot of nucleus, a lot of DNA and genetic material, and little cytoplasm. For HSIL, you're also going to see commonly irregular nuclear contours, think in 3 dimensions, and you're going to see increased nuclear size and increased mitosis. So HSIL, you can see this is full thickness atypia. You could see mites up near the top, but this would be block positive with P16. So when do you use P16 IHC? That's kind of a common quandary in pathology. It's, am I using P16? Is it always indicated? Well, we'll get into that. So it's used as a surrogate marker of high-risk HPV infection. So when the morphologic differential diagnosis is between HSIL, P16 positive, and a mimic, such as squamous metaplasia, which would be P16 negative. Or when you are considering a diagnosis of IN2, like CIN2, AIN2, which should be P16 positive, versus LSIL, which should usually be P16 negative, but again, it can be positive in LSIL, so that's not the best utility of it. And when there is disagreement between pathologists, P16 can be useful. Also, when there is a high risk for missed HSIL disease, such as an HPV positivity. So if you're trying to differentiate high grade versus reactive or a mimic, that is what I think in my mind the best utility for P16. So on the left here we have P16 positivity, which is strong, diffuse, nuclear, and cytoplasmic, with block staining along the basal layer going at least 1/3 the way up. So this is block positivity. And then on the right, this is P16 negative, which is weak or patchy. Basically anything but block positive is considered negative. And then when P16 immunohistochemistry will not help us is when the biopsy is unequivocally LSIL, HSIL, or negative morphologically. When the differential diagnosis is between LSIL and negative, as both processes are typically P16 negative. So if it's super obvious on morphology, if it's low grade, high grade, or negative, there's really no indication to order a P16. It could just confound and complicate things. And just remember, and also, P16 is not recommended to be used to differentiate between LSIL and negative. So just remember, P16 has no value outside of morphologic context. LSIL can be positive for P16, which is important to remember. P16 has a very good negative predictive value for HSIL. And just a quick little blurb on HPV. So the human papillomavirus is a sexually transmitted disease. So some of the serotypes, you have 16 and 18 are high risk, most commonly associated with HSIL and squamous cell carcinoma. 6 and 11 are low risk and most commonly associated with LSIL and condylomas. And then HPV-associated oncoprotein E6 inactivates P53, and E7 inactivates RB. And HPV usually infects the transition zone between the squamous and glandular mucosa, which is why when you're getting biopsies, it's good to comment on or just try to make sure you're in that transformation zone or that transition zone, because that's most likely where HPV is going to start causing problems. So some special circumstances to call HSIL that may go against prior rules. If there's significant nuclear atypia and abnormal mitoses, in thin SIL, less than 10 cells thick, you can still call it high grade. And keratinizing SIL, which is a markedly atypical, often pleomorphic keratinizing proliferation, and more often seen on cutaneous sites. Dysplasia extending into the endocervical glands can be a circumstance to call high grade. So I was taught at my program by an excellent GYN pathologist. If you're seeing high grade, next thing you want to assess is you want to look for, well, could there be something worse like AIS or something like that? But you also want to look for endocervical gland involvement and then comment on that as well. So here's an example of thin sill. So you can see it's not very thick, but you do have atypia and dysplastic cells in the superficial layer and in the basal layer, so this would be considered high grade. And then you have keratinizing sill with that keratinizing proliferation. Next up, we're going to talk a little bit about superficially invasive squamous cell carcinoma. This is a term recommended for minimally invasive squamous cell carcinoma that has been completely excised and might be amenable to local excisional or conservative treatment only. General requirements are invasive depth of less than or equal to 3 millimeters from the basement membrane of the point of origin, and horizontal spread of less than or equal to 7 millimeters in maximal extent, and it's completely excised. So you also report presence or absence of LVI, or lymphovascular invasion, and multifocality. If a squamous cell carcinoma does not meet these requirements, it's an invasive squamous cell carcinoma. Just leave off superficial. So some clues to invasion: you're going to have infiltrative growth, often jagged with desmoplastic and inflamed stroma, paradoxical or reverse maturation, and perineural or lymphovascular invasion, as well as infiltrating single cells and complex architecture, after excluding tangential sectioning. And then in the images, you have some infiltrating cells seen here with a desmoplastic stroma around it. So that desmoplasia is just the stroma reacting to these malignant cells, kind of causing a roughened or obscure looking stroma or desmoplastic response. And then here's an example of paradoxical or reverse maturation. So this is when the cells get pinker or more keratinizing as they go deeper, the opposite of what you would expect. And that's it. That's all we have. Just a quick episode. So this topic is really helpful. It applies to multiple systems and pathology. It goes over a lot of the fundamentals and the basics. And I hope you enjoyed it, and I hope you have a great day. Thanks for the support.